Friends, and I thank the organizers for giving me the opportunity. Well, over the last 2 years, we have all managed severe COVID-19 disease, and if you look at the core aspects of treatment in managing patients with severe COVID-19 ARDS, it revolved around four key aspects. One is antivirals. Immunomodulation had played a major role, with steroids being the major players influencing outcomes. Anticoagulation and oxygen support, depending upon the severity of the patient's clinical status. But what has been seen was, despite the use of these four interventions, the mortality was still significantly high, and that's where people were trying different therapies across the world, and that is where the idea about using mesenchymal stem cells for the management of severe COVID-19 ARDS was explored. And we know that mesenchymal stem cells are not new to medical therapies and interventions. They have been used extensively in the past. Their safety profile is well established. And in patients with severe COVID-19 ARDS, there was a very strong physiological rationale, considering the fact that when you give mesenchymal stem cells through the intravenous route, they seem to lodge in the pulmonary vascular bed, which is the site of the major pathology. And we also know that mesenchymal stem cells have significant anti-inflammatory properties, thereby modulating the immune response. And we know that the hyperimmune response was one of the key factors influencing mortality in ARDS related to COVID-19. So this had a strong physiological rationale behind the use of mesenchymal stem cells. There was also a lot of evidence or data which suggested that mesenchymal stem cells with their regenerative capabilities can help in repairing the damaged alveolar capillary membrane. Now, antimicrobial properties have also been explored, but the data for the antimicrobial properties of mesenchymal stem cells is not very strong. Now, we have data from phase 1, phase 2 trials, a lot of preclinical animal data in COVID-19 ARDS where mesenchymal stem cells have shown to have some benefit. Now, this was one of the trials which came from Germany, where they tried severe mesenchymal stem cell therapy for patients with severe COVID-19 ARDS. Well, the numbers were not very large, but again, considering the fact that this was a novel intervention, they gave mesenchymal stem cells to about 5 patients as compared to the standard of care in 18 patients. And all these patients were very sick. If you see the PF ratios, all of them had less than 100. And about 4 out of the 5 patients in the mesenchymal stem cell group were on ECMO support, and 9 of the 18 patients in the standard of care group were on ECMO support. Again, highlighting the fact that all these patients were very sick. The dosage that they used was 1 million mesenchymal stem cells per kg at a 30-minute infusion. Now, among the 5 patients, 3 patients were given 2 doses and 2 patients were given 3 doses. And what was interesting to note was that those patients who were given the stem cell therapy, the Murray score significantly decreased. Murray score is indirectly the lung injury score, and if you see from admission to discharge, the lung the improvement in the lung injury was significantly better in the stem cell therapy group. Similarly, when you look at the mortality, the patients in the stem cell therapy, the mortality rate was only 20% as compared to 55.6% in the standard of care or the control group. Now, suggesting that mesenchymal stem cells could be a potential alternative apart from your standard of care in the management of patients with severe COVID-19 disease. Now, there have been a lot of trials, though in small numbers, which have clearly established the safety, the tolerability, the effectiveness of stem cells, and the immunomodulatory properties of the stem cells, making this as one of the viable alternative approaches when you are dealing with severe COVID-19 disease. Now, the only concern that we thought when we were using mesenchymal stem cells was the cost. It was costing exorbitantly high. Ethical and legal issues from where the stem cells are sourced was a major concern. We did not know the concentration or the dosage of the stem cells which was provided, and the time for procuring. Once you place a demand or for request for stem cells, there was a significant time process before we could get it, and that is when we thought of looking at alternatives for mesenchymal stem cells, and we thought of looking at bone marrow. We all know that bone marrow, apart from having mesenchymal stem cells, also has a large number of cellular components like your hematopoietic stem cells, natural killer cells, your antigen presenting cells, regulatory cells, etc., etc. And again, in a lot of previous studies, the bone marrow stem cells have been shown to have a significant influence on both the innate as well as the adaptive immunity, and there is a good amount of data which suggests that the bone marrow stem cells drive the entire system towards an anti-inflammatory response from a pro-inflammatory response. There's also data which suggests that the bone marrow stem cells, kind of move from a MH1, the macrophage 1 to macrophage 2 system, which is more of an anti-inflammatory system. So that was what was very kind of attractive, and the evidence, the presence of data, and the fact that bone marrow stem cells have been used in the past, made us think that this could be an alternative to the mesenchymal stem cells. So we did a case series where during the second peak between May and June, about 25 patients were included, and all these patients were severe COVID-19 ARDS patients requiring oxygen supports with elevated inflammatory markers. The CD, all of them had significant CT involvement and RT-PCR positive. We chose patients who had a duration of less than 14 days because we thought that after you cross the second week, then probably the effect of any of the therapy would not be clinically significant. All the patients were explained very, very clearly about the process and the experimental nature, and only those patients or their families who consented to the procedure were included. Exclusion criteria: patients with advanced sepsis, septic shock, and already established multi-organ dysfunction syndrome were excluded. Patients who had either a suspicion or a known malignancy where the bone marrow would be ineffective, those patients were excluded. So the intervention had the use of autologous bone marrow stem cell plus the standard of care versus the standard of care, which included remdesivir, steroids. We used methylprednisolone, oxygen as needed, either it was high flow nasal cannulae or NIV or intubation, and anticoagulation. What we did was, those patients who were eligible for the study, about 50 to 100 ml of the bone marrow was aspirated from the posterior iliac spine in an aseptic way, and this was collected in an anticoagulant bag. And this, after it was collected with a heparinized syringe, this was transfused back to the patient through a 150 to 175, that is it, typical blood transfusion filter. Now, one major concern that we had was whether this could lead to fat embolism. So we did before we did this intervention, we did we had a talk with the pathologist where we examined the pre-filter and the post-filter slides, and we did not find any large aggregates of fat globules post-filter. So the risk of fat embolism was really removed by the pre-filter and the post-filter examination. Now, when you look at the demographic characteristics between those patients who were given the autologous bone marrow transplant stem cell therapy versus the standard of care, we did not find any major difference with respect to the presence of comorbid conditions or the any other conditions. The only thing was about 5 patients were intubated, 1 patient for tracheostomy, and 1 patient in the bone marrow stem cell therapy was put on ECMO therapy. When we look at the data before and after the therapy, we found that the CRP in patients who survived, there was a significant reduction in the CRP levels before and after the institution of the stem cell therapy. With respect to other inflammatory or the clinical laboratory parameters like LDH, D-dimer, we did not find much of difference. But patients who survived, their oxygen requirements came down significantly in the bone marrow group. Now, this was a line plot which showed that patients who survived, these are the patients who survived in the stem cell therapy group, and these are patients who did not survive. We found that those patients who had a positive response or who survived, the CRP had shown a significant decrease before and after the therapy with stem cell therapy. LDH did not show much of a difference. Similarly, D-dimer did not show much of a difference. But those patients who did not survive, both LDH and D-dimers, there was an increase in the levels before and after therapy. Now, again, with respect to the level of oxygen saturations, though the oxygen saturations did not change much, but the oxygen requirements had come down significantly as compared to those patients who did not survive, where we did not find this difference. So, overall, in the standard of care, all patients were given antivirals, steroids, and anticoagulation as the standard of therapy, and 25 patients among these were offered autologous bone marrow stem cell in addition to the standard of care. And as I said, all these patients were severe COVID-19 ARDS. Now, out of these 25 patients, we were able to discharge 21 patients, including the patient who was an ECMO, and 4 patients died. So when we tried to calculate the mortality rate during this period within the ICU, we found that the mortality rate in the stem cell group was 16%, which was significantly less than the 32% in the standard of care during this period in the ICU in patients with severe ARDS who were requiring oxygen support either through high flow NIV or on invasive ventilator. Well, these were small numbers, but we found that there was a dramatic improvement in a large number of patients who were given the stem cell therapy group. Now, our own data, along with data from a lot of studies across the world, do kind of put a point or put a thought that mesenchymal stem cells could be an alternative which can be thought about in patients who are having severe COVID-19 ARDS. However, we still need to explore a lot of things, right? Like, for example, we were not very sure what should be the optimal timing. And just like any other intervention in medicine, probably the best timing would be to do it as early as possible. Now, the dosage was again something that we were not very, very clear about. Now, some patients were given 1 dose, some patients required 2 doses. So whether it has to be a compulsorily 2 dose or 3 dose is something that we need to look at, and we need to explore. And even in the German study, some patients received 2 doses and some patients received 3 doses. So we are not still sure about what the dosage is. Does the type of stem cell from where we procure them, do they matter? Do bone marrow stem cells are better, or mesenchymal stem cells, or stem cells from the adipose tissue? Or does the source from where you get stem cells, will that make a difference? Is something that we need to look at. We also know that preconditioning plays a major role in the way your stem cells have an impact. So what kind of preconditioning is needed? What are the ideal patients? Well, in the bone marrow, we realize that if you want to give bone marrow stem cell therapy, then probably age should be one of the criteria, because beyond 40-45 years, the cellular components of the bone marrow may decrease, and the quantum of the number of stem cells may decrease. So it may not be a very good option in patients who are above 45-50. Now, medical, legal, and ethical implications, bone marrow stem cells have been used extensively, but mesenchymal stem cells does need to have more discussion and debates with respect to the implications. Cost, as I said, mesenchymal stem cells were very, very expensive as compared to the bone marrow, which came in within a fraction of what cost for mesenchymal stem cells. And finally, the numbers are not very large, so we would need more data to see if mesenchymal stem cells could be a viable alternative in addition to what we are doing when we are treating patients with severe COVID-19 ARDS. Thank you.